Imagine for a moment you're standing at a patient's bedside. You're not just doing the usual checks, but you're faced with these incredibly complex questions. Questions about, their peace of mind, their family's needs, maybe their deepest beliefs as they approach the end of life. How do you, as a nurse, navigate that really profound space? How do you do it with skill, but also with, well, compassion? Today, we're taking a deep dive into a really, really crucial chapter from Lewis's medical surgical nursing.
All
It's
right.
all about palliative and end of life care.
Yeah, what's so fascinating here, I think, is that this isn't just about the end itself. It's much broader. It's about optimizing life, alleviating suffering throughout the entire journey of a serious illness. So our mission today, really, is to equip you, our listener, with a clear, kind of step-by-step understanding of his holistic approach. We want to demystify some key terms and really emphasize the absolutely vital role nursing plays in making that journey as dignified and comfortable as possible.
Okay, so we'll cover what palliative care and hospice actually mean, how they connect. Then we'll give you a really practical framework, those 8 crucial domains of care. We'll definitely get into those. We'll also explore the physical changes, the psychosocial ones too, that you see as someone nears the end of life. And critically, the comprehensive nursing management, from assessment right through to intervention, always keeping the patient and their family right at the center. We'll even touch on some of the tougher ethical bits and the essential need for self-care for nurses in this field. It can be demanding. This deep dive, it's really tailor-made for every nursing student getting ready for exams or, for future practice. It's about offering a clear path to being truly well-informed without feeling, well, totally overwhelmed by all the info. We'll break down complex terms, give you real-world scenarios, and highlight how this knowledge applies, whether you're in acute care or chronic care settings. Okay, let's start right at the very beginning then. The term palliative care. It often brings specific things to mind for people, right? Sometimes misconceptions. What's the real core of it, according to our source? And what might surprise listeners about how broad it actually is?
That's a great place to start because it really does shift the perspective for a lot of people.
Mhm.
Palliative care, it's defined as the active, holistic care for individuals who are experiencing serious health-related suffering from a severe illness. Now, this illness could be acute or it could be chronic. Often it comes with a high mortality rate. But what's really crucial here is that suffering isn't just physical pain. It's much more than that. It impacts quality of life, their role function, and it creates these huge burdens from symptoms, treatment side effects, maybe caregiver stress. The main goal sounds simple, but it's profound. Reduce suffering, improve quality of life. And what's really revolutionary, I think, is that it kind of shatters that old idea that palliative care means giving up. It's actually an intensification of care. It's focused on living well, regardless of the prognosis.
And our source mentions some pretty impressive benefits that come with it, doesn't it? Improved quality of life for chronic illness, lower healthcare costs, and really easing that burden on caregivers.
Absolutely. Those are huge outcomes. And the best time for palliative care to start, it's right after the diagnosis of a serious illness. Think about things like neurodegenerative diseases, advanced cancer, heart failure, COPD, dementia, end-stage kidney disease. It's not an either thing with curative treatment either. Palliative care can be the main focus, or it can happen concurrently with therapies aimed at cure or control.
That has massive implications for every single nurse then, doesn't it? The ANA actually says every nurse should have some involvement.
Precisely. Every nurse, no matter their setting, is really expected to deliver what we call primary palliative care. So that means basic symptom management, having those routine chats about what the patient's goals are for their care, and doing a basic assessment of their psychological, social, cultural, spiritual needs. Now, when things get more complex, that's when the specialist palliative care clinicians step in. They handle the advanced symptom management, the more difficult, maybe more nuanced discussions. And this whole approach, it hinges on a real team effort, nurses, APNs, physicians, social workers, chaplains, everyone working together with empathetic communication. That's vital.
And it's not just happening in hospitals. This care is provided, well, everywhere. In people's homes, long-term care, acute care, mental health settings, rehab, even prisons. Okay, so if palliative care is that big umbrella, that support throughout the illness, how does hospice fit in? Because, lots of people use those terms almost interchangeably. But our source draws a really clear line.
Yeah, this is a really critical point of confusion. It trips people up. Hospice care is actually a subcategory of palliative care. It's specifically designed for the end-of-life phase. So it focuses intensely on symptom management, advanced care planning, spiritual care, family support, but specifically for patients in the last phases of a serious illness. The main goal there is helping patients live as fully and comfortably as they can during that time, and ultimately to die with dignity. So the criteria are quite specific then,
Yes.
especially about the prognosis.
Yes, very specific. The patient generally needs to have a limited life expectancy. Usually guideline is 6 months or less. And the focus shifts entirely to improving quality of life and comfort. That means foregoing curative treatment for the terminal illness itself. A really important insight here is that hospice often gets underutilized. People mistakenly think the patient has to be like actively dying right now to qualify. But actually, an early referral can ease so much distress and improve quality of life for longer than people might think, especially compared to aggressively fighting the illness right to the very end. Right, that distinction, all hospice is palliative care, but not all palliative care is hospice. That's a really useful takeaway. What about the specific role of the hospice nurse? What does that involve?
Oh, the hospice nurse's role is huge. It's really demanding. They're coordinating the whole team. They're experts in pain control, symptom management. They do spiritual assessments, address complex family needs. It really requires excellent teaching skills, deep compassion, flexibility, cultural competence.
Yeah.
You have to be adaptable to all sorts of patient and family situations.
But even with the clear benefits, our source points out there are real barriers to getting people into hospice care. What are some of the biggest challenges nurses run into when trying to navigate those?
That's a tough one because nurses are often right there in the middle of it. A major barrier is just, well, a lack of information, misunderstanding about what hospice actually is. People think it means giving up. Another big challenge can be cultural or ethnic factors. Sometimes there's a strong desire to keep pursuing curative treatment, or maybe a lack of diverse hospice workers who patients feel comfortable with. And sometimes, honestly, healthcare providers themselves can be hesitant. They might see a patient's decline as, I don't know, a personal failure somehow. So our job as nurses is really to educate, to advocate, and to reframe hospice as proactive, compassionate care.
And eligibility. What are the main things needed for a patient to actually get hospice services?
Okay, so for eligibility, the patient has to actively choose hospice. They need to agree in writing to give up curative treatment for their terminal illness. And then two physicians need to certify that their prognosis is likely 6 months or less. The good news is it's usually well covered by Medicare, Medicaid, and most private insurance.
Okay, understanding the definitions is one thing. But how do we actually do this in practice? Our source lays out this great framework, 8 domains. It's like a checklist for making sure care is truly holistic. Can you walk us through the basics of each one, kind of highlighting the nurse's role?
Absolutely. These domains are fantastic for guiding comprehensive, person-centered care. Let's break them down. 1. Care structure and processes. This is about coordinated care, the interprofessional team working together. Nurses here are advocates, caregivers, coordinators, educators. They do that initial assessment history, symptoms like pain or shortness of breath, advanced care plans, even social factors.
Oh.
2. Physical aspects of care. Pretty straightforward symptom management to improve well-being. Nurses need to anticipate and prevent symptoms, track them closely onset, quality, severity, what helps, what hurts, and reassess constantly.
Makes sense.
3. Psychologic and psychiatric aspects. Serious illness hits mental health hard, right? Anxiety, depression, delirium, PTSD even. Nurses are key in assessing these, getting support, working with social workers. If someone mentions suicide, immediate ITT discussion.
Crucial.
4. Social aspects of care. This looks at the environment. Does the patient have access to meds, transportation? Are there money worries? What about caregiver support? These things change, so it needs ongoing checks.
Right, the whole picture.
5. Spiritual, religious, and existential aspects. This is where holistic really shines. Spirituality is broad beliefs, values, purpose, meaning, not always religion. Nurses need to assess spiritual needs, respect preferences, spot spiritual distress, and know when to call the chaplain.
That's so important.
6. Cultural care. Culture impacts everything, views on health, illness, family roles, decision-making, even how symptoms like pain are expressed. Nurses need to be culturally competent, assess nonverbal cues, consider language, use interpreters. Different faiths have specific needs, like around death rituals or organ donation.
Very important to be aware of those differences.
7. Care of the patient nearing end of life. This is when health is declining, even if death isn't like right now. Goals are clear. Comfort, support, quality of life, dignified death, family support. Talking about hospice early is key here.
Okay.
8. Ethical and legal aspects. This is where the tough decisions often lie, and nurses are right in the middle. It's all about honoring patient wishes. Think advanced care planning, talking about and documenting values and goals. The advanced directives are the actual documents, living wills, durable power of attorney for healthcare, or DPAHC, spelling out wishes or naming a decision maker. PLC forms are state-specific medical orders for treatment preferences.
And these cover things like CPR decisions too, right? Those DNR orders.
Exactly. Discussions about full code versus do not resuscitate DNR or DNAR or allow natural death, A&D. It's vital to stress that these orders never mean withholding care. Care just focuses on comfort and dignity, not resuscitation attempts. Patient choices about organ donation also fall under this, governed by specific legal guidelines.
What about really sensitive topics like euthanasia? Where do nurses stand?
Okay, so euthanasia, the direct act of ending a life, is illegal everywhere in the U.S. and goes against nursing ethics, according to the ANA. Now, physician-assisted suicide, sometimes called aid in dying, is legal in some states. That's where a physician provides the means for a terminally ill patient to end their own lives. As nurses, our role is to know the laws in our state, provide comprehensive end-of-life care, but not to administer that aid in dying medication. It's also really important to distinguish that from palliative sedation. They sound similar, but are ethically different. Palliative sedation is about intentionally using sedation to relieve unbearable symptoms when someone is very close to death. The intent is symptom relief, not shortening life.
And the chapter brings up a really powerful ethical point about pain management with opioids. That's a huge concern for many nurses, isn't it? Fear of causing harm.
It is, and this is fundamental. Adequate pain relief at the end of life is basically a patient's right. Opioids are the gold standard for managing severe pain and also shortness of breath, or dyspnea, even if they might cause sedation as a side effect. The ethical principle here is called double effect. It says it's okay to give opioids to relieve suffering, even if a secondary unintended effect is sedation. Why? Because the intent is to ease suffering, not to hasten death. Actually, withholding opioids because you're afraid of addiction or, hastening death that's considered below the standard of care. That's a critical thing for nurses to grasp.
Okay, moving on then. Let's talk about what actually happens physically as the body transitions towards death. It's important for nurses to know what to expect, right? Not just for practice, but also to explain things clearly to families who are often scared and confused.
Absolutely. Yeah. So clinically, death is the irreversible stopping of all vital organs and systems. Okay. There's also brain death, which is a specific clinical diagnosis. Coma, no brainstem reflexes, apnea. That's especially relevant for organ donation discussions. As death gets closer, the body just gradually slows down. Our source has a great table, but let's hit some key physical changes you'll likely see. Respiratory, breathing might get rapid, then shallow, maybe irregular. You might hear those wet gurgling sounds, terminal secretions, or the death rattle. And sometimes change those breathing that pattern of pauses, then deep, rapid breaths. Yeah. Cardiovascular, heart rate might speed up first, then slow down. Pulse gets weak, irregular. Blood pressure drops. Neurologic, often more confusion, maybe delirium, sometimes hallucinations. Temperature can swing wildly. And hearing is usually the very last sense to go. That's important for families to know.
What, the last sense? Skin?
Skin. You want to see modeling that sort of purplish, blotchy look, often on hands, feet, the sacrum. Skin can get cool, clammy, maybe look a bit waxy.
And beyond the physical, there's that huge emotional journey. Grief and bereavement. People often mix those terms up. Can you clarify them?
Good point. They are different. Bereavement is simply the state of having lost someone. Grief is the reaction to that loss. And grief is, well, it's normal, but it's complex and intense. So emotionally, you see anger, guilt, anxiety, deep sadness, depression. Physically, too, sleep problems, appetite changes, even actual physical symptoms can pop up.
Our source talks about grief having phases, but also makes it clear it's not always like a straight line.
Yeah. Exactly. Phases like shock, denial, anger, bargaining, depression, acceptance. They're common ways to describe it, but people bounce around. It's not neat. The grief wheel model maybe captures it better, moving from normal through shock, protest, disorganization, reorganization, and eventually finding a new normal. The real challenge is accepting that new normal, not trying to get back to how things were before. We also need to think about anticipatory grief, the grief that starts before the death, affecting both patients and their families. And while adaptive grief is healthy, sometimes people experience prolonged grief disorder, really intense, long-lasting mourning that needs professional help. For nurses, the priority is creating a safe space for people to express whatever they're feeling, being honest, respecting privacy.
Okay, this is really where the rubber meets the road for nursing practice. The source gives us a fantastic roadmap for nursing management, really emphasizing that compassionate, patient-centered approach.
Exactly right. Even when we know a cure isn't possible, the nursing process doesn't stop. Assessment, planning, implementation, evaluation, still totally vital. The focus just shifts. Right? It shifts to symptom management, comfort, and always always upholding respect and dignity for the patient and family. In assessment, we need to be really sensitive. Avoid poking and prodding unnecessarily. Use the records we have. Focus on function, comfort, how everyone's coping. In those final hours, assessments get really streamlined. Comfort is key, pain, breathing. Don't do tasks that won't help with comfort.
So the planning goals become entirely about what the patient wants and about comfort.
Precisely. The big goals are the patient directs their end-of-life care decisions, and they experience a peaceful, dignified death. Planning means actively involving the patient and family. What do they need for comfort, safety? What are their emotional needs? Where do they want to be when they die?
Got it. Now, implementation. Let's start with the psychosocial side. The source has great tips there.
Yeah, social care is huge. It's about helping prepare for death, encouraging people to share feelings, say goodbye, maybe just hold hands. We need to facilitate spiritual support if wanted and recognize spiritual distress. We also manage those tough things like anxiety, depression, maybe anger, hopelessness, or common fears, fear of pain, fear of being breathless, fear of being alone. For instance, making sure pain meds are given regularly, around the clock, plus non-drug comfort measures. That directly tackles the fear of pain. And communication. It's about empathy, active listening, sometimes just being silent and present, especially if the patient's cognition changes near the end.
The chapter also has a really detailed table on physical care, managing all those different symptoms. It's a lot to take in. What are the absolute must-knows, the critical physical care points for nurses?
Okay, yeah, that table is comprehensive. Physical care boils down to symptom management and comfort, meeting needs for oxygen, pain relief, skin care. Dying patients deserve the same careful physical attention as anyone else. Instead of listing everything, let's hit a few really key areas. Anorexia, dehydration, nausea. The big thing here is don't force food. Offer small, appealing meals. Meticulous mouth care is essential. And educate families decreased appetite and thirst are normal, not neglect. Use anti-nausea meds if needed.
Okay, that education piece is vital.
Respiratory distress, dyspnea and secretions. Assess breathing and anxiety. Elevate the head, maybe use a fan. Opioids work well for dyspnea. Anticholinergic meds can help dry up those death rattle secretions. Comfort is the goal, so avoid aggressive suctioning.
Got it. Comfort first.
Skin breakdown. Prevention. Keep skin clean and dry. Reposition gently. Use barrier creams. If breakdown happens, manage wounds carefully. Maybe pre-medicate for dressing changes. Maintaining dignity is part of skin care. Pain. Assess thoroughly and regularly. Around-the-clock meds are usually best. Use different routes to swallowing as hard patches, liquids, rectal. Don't forget non-drug methods, massage, music. And remember that double effect principle, relieve the pain.
And then after the patient has died, there's the very sensitive task of postmortem care.
Yes, postmortem care needs tremendous sensitivity and respect. It's about giving the family privacy, honoring any cultural or religious practices, gently closing the eyes and jaw, putting dentures back in, removing tubes and dressings according to facility policy, washing the patient gently, putting on a clean gown or their clothes, positioning the body naturally, and critically, giving the family undisturbed time, and always, always use the patient's name. Never refer to them as the body.
Finally, and this is so important, we can't forget the toll this takes on family caregivers, and of course on nurses too. This kind of care is incredibly draining.
Oh, absolutely. Family caregivers are often the unsung heroes, but they face huge emotional, physical, sometimes financial burdens. Nurses need to be alert for signs that a caregiver isn't coping well. Maybe prolonged depression, trouble expressing feelings, substance use. Supporting them means encouraging them to take breaks, maintain some normalcy, and connecting them with resources, respite care, counseling, support groups.
And for the nurses themselves, that self-care piece is critical, isn't it?
It's non-negotiable, really. Caring for dying patients is deeply rewarding, yes, but it's intense. It's emotionally charged. Nurses form bonds. We're human. We feel loss, grief, sometimes helplessness or frustration. It's so important to recognize your own feelings, understand your own values about death, and know it's okay to cry sometimes. Prioritizing self-care isn't selfish. It's essential for sustainability in this work. Have hobbies, take time off, get enough sleep. Lean on your peers, build support systems outside of work. Hospice agencies actually often have great support programs for their staff because they know how demanding it is.
Wow, okay. We have covered a lot of ground today. A truly deep dive into palliative and end-of-life care. So much vital information for your nursing journey.
Yeah, if you try to boil it down to the big picture, the main clinical takeaways are probably these. Palliative care is proactive, it's holistic, it's patient and family-centered. It aims to improve quality of life through the whole illness, not just right at the very end. And hospice, remember, it's a specific type of palliative care, for when the prognosis is limited, focusing entirely on comfort and dignity.
And remember, as nurses, you really are on the front line. You're not just looking at physical signs, you're navigating all those complex psychosocial things. You're dealing with ethical choices around advanced directives, pain relief. You're providing that deeply compassionate, dignified care. And you're supporting grieving families. And just as importantly, supporting yourselves through it all.
Which really leaves us with a question for you to think about, doesn't it? How will you take this holistic philosophy of palliative care and weave it into every part of your nursing practice, regardless of your specialty, regardless of the patient's prognosis? How will you use it to truly ease suffering and promote dignity?
Thank you so much for joining us for this deep dive. We really hope it's giving you some clarity, maybe more confidence, perhaps even a few aha moments as you navigate the complexities of nursing. Keep learning, keep growing, and keep making that incredible difference.